count on us for you can count on us for making sure that we're following this great work at detail. So I think from right there we can jump right in. Oh yes, and I just quick moment too is that our programming, again, if you're new, and if you are new, if you can please, and if you're not new, if you could please introduce yourself on the chat, especially for our guest speakers to know who and how diverse our group is, that would be great. So please enter your introduce yourself into the chat. But this has really given us our programming for the year, where we're looking at what are the kind of key elements of all these use cases that are priorities and goals of the state. So this is how we're looking at bringing in guest speakers and also education opportunities. And then, drilling us back down always on 2 priority use cases that we honed in on last year. That is immunization data and really public health use cases, and then CalAIM. And John, I think this isn't a surprise for you either. So it keeps our focus of our work. So with that, I want to introduce John Ohanian. John is the Chief Data Officer and the director of a newly stood up organization, the Center for Data Insights and Innovation. And this is all within agency at the California Health and Human Services Agency. So John, we really appreciate your leadership and gosh, working at the speed of light over the last few months to be able to pull together such a broad base of stakeholders, and then not only at the high level, at this steering level, but then also the work that you're doing with data identity and also the data sharing agreement. We really look forward for you joining us today. I think, we could probably spend the entire hour with both guest speakers. We're looking at about 20 minutes, so I'll try to keep us on time. But John, I'm going to hand it over to you.
Excellent. Well, thank you, Timmy. Thank you, everyone, for having me here today. This is a really great opportunity to share some of our work. I see a lot of familiar faces around and names, so a lot of you are very familiar with our work, so maybe we can have more of a dialogue. I think that's always more enjoyable over these Zoom encounters. But like Timmy said, I'm the Chief Data Officer, the first Chief Data Officer that Cal HHS hired. I came in about a month before, well, actually, I think a month before my official start, May 4th of 2020, but came in during the lockdown in April. I don't know why, but I seem to have an affinity to start jobs in the middle of crisis. My job before that was running the 211 in San Diego, and I started in 2007, about a month before the 2007 fires, where we found ourselves in the midst of using that utility for the first time in disasters. So for those that know me, I really do appreciate a challenge. And these definitely, the last 2 years have definitely proven that. I was brought on initially to stand up the Center for Data Insights and Innovation, which is an internally focused startup within agency with 2 focus. One is to bring the incredible amount, massive data that we have throughout our quote $200 billion in programs and 30,000 employees together so that we can have a more person-centered view of our client and improve delivery, as well as making more data-informed decisions when we're making both financial decisions at a state level. I call it more the business intelligence of the agency. Back when AB 133 was signed, I was brought in to lead the effort, probably for a number of reasons. Shortest straw could be one of them, but as all of us know, so much of the service delivery system is outside of the state. Folks like yourselves, social service providers, and kind of continuing the mission that we had in San Diego of how do we deliver better services? We bring that data together to the providers so that we can improve care and reduce churn of individuals. On a personal level, in the last 10 years, I've lost both my grandparents and my parents, and I was their provider, both their caregiver on their health side, but also their social needs. And I know that I needed better information. I know that I struggled a lot. And here I was the CEO of the social service organization that had the information source in San Diego, and I struggled to get that. And I think we all have our own personal stories. And so while this initiative has been really a challenging one, because anytime you're trying to bring people with differing views and different sides together, which is really the foundation of our country, it's challenging work. But I will say that what I continue to hear from our stakeholders, while I get their feedback of why things should be one way or another, I think we all hold the common goal and excitement that this is actually happening, and we're going to make it happen. So it's really an honor to be a part of such important work, where I feel like I am definitely the least knowledgeable when I look around a room like this in terms of certain technicalities. So I think it's my job to really be someone who can listen and learn, understand these issues at a very, I call it the 5th grade level, because sometimes then the most, I think, maybe natural step or solution can provide, or at least I can better understand what the differing issues are and maybe where we can find common ground. So with that, I never expected to work at the United Nations. I will say this seems like a first test run, and my boss, the Undersecretary Marco Meach, I think is an incredible, exceptional leader to be able to make. I think that was really a secret sauce behind getting people to the table to get AB 133 through. And I hold a great degree of trepidation, but also excitement to carry it through and get it landed by June 30th. So with that, I didn't want to get into all the technical pieces because I think a lot of you know about it, but I did put in the chat our timeline, our approach, lots of information. And I would say to all of you, thank you for having me here. Please come join us and be a part of this. If I can ask this, the little group that is knowledgeable, if you can raise your hand if you are pretty in tune with what's happening with AB 133. Maybe pull my group here. You guys know how to use the hands up. Stephen Lane knows how to use his hands. There we go. Yeah, you can do, okay. And then a shy group of no thumbs. Okay. So with that, I know that I can occupy 10 minutes of talking. I may have come close. If I see some fun emojis out there. So take a look at the chat, and then maybe we can, if the folks around that are familiar with AB 133 want me to highlight anything in particular, other than the overall guise of we all as providers have information that we have all come together and agreed that we know that we need to share it at some level to help the people that we serve. So Timmy, I'll kick it back to you. You're on mute.
I'll get us started with a few questions. I think we really wanted this to be, how can we get as much information out of you in this time that we have? And then I would also welcome for all of you who are on today, if you have questions for John, let's queue them up either in the chat or make sure if you raise your hand, it's for a question, not for the last survey we had. Lori, is that a question? I see. Okay, so put your hand down so that if I can see, if you have a question, I can see it and I can call on you. So Lori has a question. Can you expand on the state's focus on the non-HIPAA covered entities, such as social services? That's a great place to start.
In terms of, okay, so I guess the best way that I can say this is, obviously the initiative has a lot of focus on sharing health information, but we know that the health providers over the last 10, 15 years have really built expertise and are doing this work. They are sharing information. Mental health providers are sharing, communities are sharing information. So don't get me wrong that that's not happening. But as you see here, the social service sector, which I feel like I know intimately just in my past experience, but not all, is to really know that social services are a core component of someone's overall health. And having a provider know that an individual needs medication is great, but if they don't have a home, if they don't have power, that limitation, these social determinants of health really kick up. And so our secretary, obviously, he said that if he could rename CalHHS, he would make it the Human and Health Services Agency, because so much of our work, and we know worldwide that good focus and investment in social services are a great precursor to someone's overall better health. So I would say that, if we talked about a mission of having a person-centered view of someone's overall health, it would include those social service support systems to know if someone's on certain benefits, to know when those renewal dates are, to know if maybe what service providers are helping that individual as a way to coordinate care. I think that it's not, when we say states focus, I think it's all of ours. I think we have brought together a coalition and stakeholder group that bring a lot of different input from all over the state that know what type of information might be the most needed and usable for an individual to have, as well as their provider. So through that, I think we'll get a lot clearer on that list, but we're trying not to boil the ocean, and we're trying to focus on key areas that focus on safety and well-being of individuals. Hopefully over time, it'll continue to grow.
Katie, I see you have a question. I'm going to get to it in a second. But John, I just want to, I think on the lines of working with social services, there's been a lot of discussion within our group around the urgency of meeting the needs of COVID, for example, or meeting the needs of, or aligning what's being stood up by the state with these really large initiatives that I think we all recognize we need, yet they may not be plugged into that existing data infrastructure or even acknowledge that it needs to be part of the design of those systems. So one thing that there's this kind of frustration is that although you're getting big initiatives lifted off the ground, where is this work that's happening on the data exchange framework kind of plugged in? Do you have some thoughts there?
Well, I think it's the foundation for all that work. We can have a lot of initiatives, but they can only go so far without this interconnected system. So,
Right.
I'm not the best person with analogies, but I could always come back to freeways and roads. Is we have just incredible. We have an incredible exchange environment out there. We have incredible HIEs out there. We have providers. We have technology. This whole point of AB 133 is really, we have incredible networks. How do we create a network of networks? So that's the approach. We're doing the same thing internally at the state. We have large initiatives. Every initiative, whether it's a department focused initiative, involves data and programs and services that are beyond. Social services is working on initiatives to improve, whether it's children's health, well-being, cradle to career. Those require educational data. They require data not only in different departments within Cal HHS, but within the state and then outside of the state. So in this world of us all wanting more access to information and bringing together a total picture, certain foundational infrastructures need to be in place. So other states have implemented HIE statewide and have done it long before us. We in the state before my time have taken a different approach, and now there's these last miles of connections that can make a big impact. And so I think it's leveraging in my social service environment, and I see Dan Chavez on the line. When I was at 201 and he was at HIE, we didn't try to reinvent it. We went and said, we just, from a social service environment, we have a lot to learn from what's happened in the health information exchange to be able to adapt it to our area. Does that help?
It does. And I guess there's, when we see a roadblock, and we just had Lanes come on last week and talked about almost a year worth of back and forth between the county and the state to get a data exchange agreement to deal with COVID, which I think is really, we could have done better there. But when we have these roadblocks, and I was up at State of Health Reform yesterday, State of Reform up in Sacramento, and we had a conversation around just doing basic quality data that is done with commercial health plans is really missing for Medi-Cal managed care plans, because that data isn't flowing into the, into those quality databases. And there just seems to be, can we use, I'm going to say it, can we use you when these roadblocks come up to be able to help point us in a better direction and be, quicker with doing some of these problem solvings when it comes to data, or someone else, let us know.
Well, way to put me on the spot, but I would say
I
my answer is yes. I mean, look, if I
get that vibe.
then I'm with the state. and I feel like that is not a side, that is like all of us. I feel very honored to be in this spot, so I will not turn a call away. I think folks that are here have reached out, we have engaged. We also have a public process. We have Bagley Keene, which I've learned all about. So I would say bring that. We have public comment at every one of our monthly meetings. Bring those up. That is the channel. That is the avenue. It gives me the ability to hear it, but it also allows the experts that are in that room to say yes, and here's how we can do it. You have not only folks that are outside, but we have all key leadership from our departments involved, engaged in this work. So I get that there's a lot of problems. I have a printer outside my door that I've been trying to get fixed, right? Like those types of things that we know that maybe we don't do as well. But I think the one thing that we can do, and being in this role allows me to do, is bring people together to do that work. I see a note in the chat. If someone could maybe copy paste the data exchange framework, all the meeting information is out there. And I really came to this meeting knowing that there's probably a lot of problems that we need to get to. I'm not here saying I can solve them all, but I am saying that I will listen, and I'm here. That's my job. And at least at the end of the day, I think when people don't agree, or we might have those, but I think there's a lot more that we can do. And I think it's almost timing, right? COVID has been an accelerant, our secretary says, about so many ideas. It's also been really limiting in how much we've been able to get done by getting out from under it. I feel like that's happening. I feel other people, we go to the stores, we're like, is this right? We don't, is this happening? And now that we're at this point, I think it is a time for us to just continue to dig in, and you see our aggressive timeline, but the work doesn't stop in June. Just like many states who implemented HIEs, they didn't solve it when they started their HIE 8 years ago. It was just the beginning of working together in a way that we haven't been able to.
Well, thank you. Thank you for your generosity and letting me put you on the spot there. And I love the idea of using public comment. So I'm making that known to everyone here too. Katie, I know you have a couple questions. I'm going to drop it over to you.
Oh, sure. Thanks, Timmy. I think that this, John, thank you so much for joining us today. It's so great to hear directly from you. I'm Katie Hydorn. I'm the Executive Director of Ensure the Uninsured Project, and also a now Cal HHS alum from the Brown administration. So love watching all of the amazing work that you and the team are doing on this. It's really great to see all of this moving forward. I just want to follow up on just underscore again the engagement with our human services partners, and that we at Iehp have tried at our conference about a month ago, trying to lift up some of these examples of these community exchange opportunities. So I was just curious if you've met with any of them. I know you have an extensive stakeholder framework, but going forward, I know that you're sort of engaging community-based organizations, but are you thinking longer term how you're going to actually actively engage them, maybe around CalAIM, and actually provide some funds? I know you may not be able to speak to this, but on that infrastructure and how you actually, kind of like we did with the High Tech Act, but can we do this is that on the agenda to even think about for either community-based organizations or even in counties, the county public health departments who might not be the county HHS agencies or some of their local partners? Would love to hear a little bit about that.
That would be ideal, right? The ideal situation is that, and the best way to do it, I don't know, and I'd look for feedback of other programs, maybe currently or past, that really knew how to engage. I remember, one of my mentors was Supervisor Greg Cox down in San Diego, and he would always talk about how all programs are local, right? And we've heard that before. It's not his cliche, but it was, he was with the state at one point, and then he was with the county, and it was like, we can get things done. And so what I always ask others is, at the state level, where can we be helpful? We don't, gone are the days where, because I lived in a local area where initiatives would come at us from the outside thinking that it was the newest thing. And we were like, well, we actually just need to continue to build on this. And we knew that the relationships that we had were important. But I think some of the areas we can be helpful is seeing at a state level or at a national level, how can we share some best practices? How can we make sure that we are there's that open two-way communication? We have this framework, which I think is brought, and in COVID, with being able to, kind of step aside Bagley Keene in some respects or virtualize it, I think was really good. I mean, I don't know if I would have
Yeah.
had that much engagement, which has helped. I don't know specifically. I mean, I know that now that things are starting to open up, my hope is maybe possibly some travel to get into some of these communities and be out there and hear directly from them. Maybe it's a way through our public comment or just people reaching out saying, we have this coalition, we're doing this great work, we'd like to talk to others that are, or here are our roadblocks that we're facing in each of these areas. And if there's a better way to get that input so that we can find out that information without doing a lot of work, because people are maybe this forum here.
Yeah, we can do that.
Yeah.
Yeah,
Yeah,
I know we've talked about that, but yeah, Timmy, I feel like we have a couple examples and some recordings of some of our panels that might start that conversation. Would love to get them to you either via Timmy or directly. So thank you so much.
Thank you.
And I think that's a really good way to like maybe throw a last question out, which is how can we help you? Here we have real supporters of accelerating data exchange throughout the state, and how do you envision us being able to help you now and then post July?
Sure. Well, it goes both ways, right? I think empathy goes a long way as a first starter, but not let it be a precursor to not do something, right? Like we have a big initiative ahead of us, but we also have a lot of good momentum behind us as well and possibilities. So I would just kind of go back to what I said. I think that how this stakeholder group is going to continue to evolve, being a part of that process for me is helpful. Being real and honest and reach out to me if I say something or you're seeing something that you really have issue with, because if you have issue with it, probably others do. Maybe there's information that we just haven't shared, couldn't share, or just don't think to share because we think, I mean, anytime you make a presentation, you have that hope or fear that you might not have explained yourself correctly, or there's context and everything. I think the best thing we can all do, and maybe it's kind of feeling after we get out of COVID, is this is one team here, and any one of us could be in any one spot with any one label of an organization that we represent. But at the end of the day, when your kids or grandkids are taking care of you, do you want them to have access to that information? How about that? Let's make it really personal. Let's get this done. Thank you.
Wonderful. Thank you. Thank you for your work. We will continue to support the effort. And I would just also offer, if there are items that you want to kind of punt over to be able to get us to get some thoughts on, we're here for you. And as Katie said too, we are welcome. We also welcome to be able to host different, listening sessions or whatever you may need.
I think that's great. I know you're stopping, but I would say like the piece that I think is really important for all of us is the why of all this work. And each one of us has a different one. That's important. We want to know all the difference, right? The community providers, the EMS workers, the doctors, the individuals that are caregivers, social and mental health issues, things. We're looking at all these vignettes of how this can, and so when you think about focus, that's when you talk about the areas that maybe you think we should be focusing on is what's the use case? How do we get to getting something in place so that we can, all these ideas have as a way of once you operationalize them, they're actually in place. But starting small and getting there and making progress, I think for a group like this would be important as well.
Terrific. Well, if there are other questions, if you have other questions for John, please put them in the chat. John will get those over to you. We welcome you to stay on. Thank you. And our next presenter is about Iehp, the Inland Empire Health Plan, and all of their work over the last several years on incentivizing data exchange. And I am pleased to introduce Jania Fick, who's the Vice President of Quality. Jania, I think you're on.
I am. Great.
Oh, there you are. Great.
Hi.
Thanks, Jania. Take it away.
All right. Well, thank you for having me. And I'm excited to get to share with you a little bit about the journey that we've been on at the Inland Empire Health Plan around our journey to connect our network providers, specifically our hospitals and our outpatient providers to the HIE. So if we go to the next slide, what I'll cover today is I'm going to go just a quick overview of the Inland Empire Health Plan, and then also a quick overview of our pay for performance programs, because that's the vehicle we leveraged to do this work. And then I'm going to spend the majority of the time just walking through the journey that we had with our hospital network in the first 4 years of the program. And then I'll end with talking a little bit about what we've started this year with our primary care network journey. So I'll go on to the next slide. So starting with who IEHP is, just from a member perspective, we are responsible for managing the care of 1.5 million members. The majority of that population is in Medi-Cal. And then we also have our CalMedi Connect product line as well. As far as the structure of our health plan, we are a joint powers agency, not-for-profit health plan. And we work within 2 counties in Southern California, San Bernardino and Riverside. We were established in 1996 and we're a mixed model HMO. We're happy to say that we're NCQA accredited. And we have a very robust network of providers. And so you can see here kind of that breakdown. And what I'll be talking about today is really focusing around the work we did with our hospitals and our primary care providers. And I think it's just important also to just highlight who we are as an organization. Our mission is to heal and inspire the human spirit. And our vision is that we will not rest until our communities enjoy optimal care and vibrant health. And so moving into our pay for performance programs, next slide, please. The purpose of our programs is really to create incentive payment opportunities that reward our providers for both improvement and attainment in providing high quality care to our members. And we offer various programs to different segments of our provider network, including hospitals and primary care providers. And that's what I'll be highlighting today. Next slide. So moving into this, connection to the HIE, what we wanted to do at IEHP was to leverage existing P4P programs to help encourage provider engagement and data sharing. That was what we were really, planning to do. And our goal was to connect our network providers specifically to our HIE in the region in order to better coordinate care across our very diverse, very expansive region that has a lot of solo practice providers, as well as a lot of independent hospitals across the region. And so our approach was to provide financial incentives to guide providers through this journey. And we wanted to start with our hospital partners. And we did that kind of through this kind of basic kind of high level framework. We wanted to just get our hospitals first, just started to share data. And then as we got folks signed up, we wanted to then progress into improving data quality, expanding our data elements that are kind of captured within the data exchange. And then again, the data quality improvement really is just an ongoing effort that we anticipate being kind of a continuation as we learn and grow in this space. Next slide. So these next couple of slides are a bit dense, but I wanted to provide as much information that might be helpful. The way we structured our approach with our hospital partners was to start off in year 1 with building awareness and engaging our hospitals to learn more about the opportunities that may exist for their organization with the data that they could have access to by connecting to the HIE. And so we really had 2 requirements. The first was to get them signed up and meet some very basic data reporting requirements. And so we just wanted to kind of just get that pipeline started and connected. And then we had a performance measure where we wanted them to actively use our HIE portal to query a certain number of patient records throughout the period, just so that they could start to learn and understand more about what data is currently in the HIE that would be beyond their own hospital walls. So that was our year 1 objective. And then really the strategy was each year we wanted to build upon what we've already gained from the prior year. So moving into year 2, our objective was then to look at improving data completeness and expanding our data capture to include more elements. So we introduced a new program requirement that became an ongoing requirement. So we started it in year 2 and it continues on till today. where we do require our hospitals to provide the plan staff access to their EMR. And that's being used to help validate information exchange and just help us better understand how this information is flowing through, and also to support our care managers during care transition workflows. And we thought that was an important piece, just fundamentally to have that ability to see and check the data as we're learning more about the information that's flowing in. Two performance measures that we introduced was, again, building on what we had done originally with those baseline reporting requirements in year one, plus we added a consistency factor. We wanted to see that the hospitals were consistently reporting throughout the entire measurement period, and we would assess hospitals on a quarterly basis. So we were looking to see throughout that quarter, were they submitting all of the expected data sets continuously throughout the quarter. We also introduced, as our second measure, new reporting requirements that included additional data elements that were not there in year one, with milestones, that we were asking them to meet, and would provide them with incentives if they met those new milestone markers for sharing new data with us. Next slide. So moving into then year three, again, building on the work from year two, our objective here was to improve data completeness and then really just actively monitor, because one of the things we learned was we needed to get better at anticipating when problems may be happening, because if we wanted to build workflows around this data coming into the health plan, we really wanted to have confidence that the data would be continuously flowing in. And if there was an issue with the information flowing, that we would be actively alerted in real time, so that we wouldn't have a system being down for too long. So that was really our focus in year three, was to improve on getting those monitoring reports in more real time. And again, measuring that the data was continuing to flow through the entire measurement period consistently. Year four, oops, actually, I know there's a lot here. Year four is, again, continuing to improve data quality, and then just expanding on our quality checks. And I think what we were learning is, as we started to use the data more and more, we understood it better, and we're able to then create more refined sort of edit requirements or validity checks throughout this process. Year five is our current year, and we're just continuing to partner with our hospitals on improving data quality, and again, just continuing to build out our quality standards that we have in place as we're receiving the data from into the HIE. Next slide. So that was kind of the framework under the P4P program, and kind of happening in parallel was, as a health plan, we were looking to see how could we then leverage this information to help support business operations and ultimately improve the quality of care that's being provided to our members. And so starting with year one, our approach was to concurrently introduce, as we were starting this new HIE awareness and connectivity measure, we also introduced a post-discharge follow-up measure for our hospitals. And so this was really asking them to start engaging in a more intentional way with our outpatient provider network to help support members, right, having a safe care transition. So helping them secure that post-discharge follow-up appointment with whatever physician they needed to see. And we were measuring that as a new measure in our incentive program. Again, this is starting to get the hospitals aware that we really wanted their partnership in a bigger way beyond their four walls of the hospital system. Moving into year two, we began to use the data feed that was flowing in from the HIE, and we were able to partner, our IT teams were able to partner to figure out a way to feed that information into our medical management systems to support our inpatient workflows. So again, supporting care transitions was really important here for us. Year three, we began to share this data with our primary care provider network, and provided them with easy ways for them to see their assigned patients who have just been discharged. And again, because this data is coming in real time, it was really helpful for us to then be able to share that information much more timely than if we were to be relying on claims data, which would have been 30 days in the past. So this was really exciting for us to then start to use this information to share with our primary care providers. And we then concurrently introduced a new measure in the P4P side for primary care, also looking to promote that timely follow-up post-discharge care. Next slide. So looking at outcomes and kind of some of the measures that we were tracking along this journey, starting with just some of the basic process measures, we were initially starting out with 29 hospitals who were within our geographic region that we were really engaging in this work. And we were really successful after year one, getting everyone connected and signed up. We did lose one hospital in that journey throughout the 5 years. But we are still at a 96% engagement rate today. And we have 28 of the 29 hospitals actively sharing emergency department and acute inpatient data, information flowing into the HIE in a real-time manner today. When we look at data quality, again, this is where we were getting better as we learned more about the information that was flowing in. And so we actually started to measure in a much more difficult way. So what you can see here is our rates are actually declining, but that's actually because we're getting a little bit more prescriptive on what we're expecting to see. And so we're not discouraged by this. We do anticipate that we'll see this start to trend up as we stabilize kind of the requirements. But I just wanted to share the transparency of the journey. It's not, a straight upward line. It does require a bit of kind of learning and understanding and adjusting on that front. When we look at outcome measures, we do see that our members were starting to actually start to see some benefits with this new system connectivity, with our baseline year of 43% of the members getting timely post-discharge visits within that 7-day period. And we're now up to 48%. And that's actually a statistically significant increase for us. And we did meet our initial goal of getting to at least 47%. Another outcome measure that we've been tracking at the plan level is our observed readmission rate. And our goal again was to get that number as low as possible. And we did in fact meet our goal of getting below the 9%. And I think we'll go to the next slide here. Yeah, so moving into what's next. So that was our journey and we're still on it with our hospitals, but we really want to be much more focused now on our primary care engagement and connections. And so we've introduced a similar approach now with our primary care network in our P4P program, where we're starting with year one to get them signed up and just start reporting. But I think one of the things we've learned through our hospital journey is that the quality of data is really important. And the sooner we can get ahead of that at the early stages of engagement, the better we'll be. And so what you'll notice different here is that in addition to getting signed up and start reporting, we are requiring this passing primary source verification, which is just an activity of validating and ensuring that the data connections are sound and support some of the expectations around use around HEDIS reporting and NCQA. And so we really wanted to be intentional here with our primary care connections to have that extra step of verifying that the primary source is connected the way we would expect. So we're planning to sort of go on a similar path that we did with our hospitals, but again, starting with data quality out the gate. Our use case here for year one is that we anticipate using this data set in our HEDIS reporting and other quality improvement monitoring efforts at the plan. So we want to actively, consume the information and kind of integrate it with other data that the plan has so that we can get a better sense of the care that's really needed, the care that's happening in more real time. And we are partnering with our HIE vendor to be engaging in the NCQA data aggregator validation, I think is what it's called, program, DAV program, so that we can leverage it for HEDIS reporting. And I think that's my last slide.
That's incredible, Jania. And I know that we've all been really eager to learn more about this work. And I just wanted to clarify that in your pay for performance program, this is a component of it. So
It
is
is
this
component.
a on off, you either participate and meet these needs and you get paid, or is there some kind of scale of getting paid with others?
Yes,
I'm sure there's lots of other things in your performance program.
it's one of various measures within the program. So there's different ways our hospitals or our primary care providers can earn incentive dollars. So this is one of, a subset. And the way that we're structuring it is, we kind of started off as give them a couple of opportunities to earn incentive dollars, hit this milestone early in the year. That would be the maximum dollars you could earn. And if you need a little bit more time, we'll give you another opportunity to earn dollars, but it'll be not as much money. And so we do create kind of like a tiering system within the program itself to give hospitals a couple of ways to hit those targets, so that it's not an all or nothing, but we're trying to really encourage, early and, of course, complete, submissions.
That's terrific. And I just think the call out there is that the more we can do to align these incentives across the state from a provider's point of view, because it's easier to be able to do this adoption if all plans
Yes.
are aligning around the same metric. So that's my plug for collaboration. But thank you for leading the way here. And I see a couple of questions. So Lisa Lucas just put one in around, what are you doing for primary source validation? Are you validating the data received is what is sent, and also incorporating data quality? So I guess that's what you were talking about, your algorithms.
Yes, so I'm not an expert in this space, but there is a new NCQA program that's allowing HIEs to actually sign up and become a certified entity to provide data in a way that can be leveraged by a health plan in their HEDIS reporting. And so it's called that DAV program. And so within the DAV program, one of the steps that the HIE has to do is with NCQA is go through this primary source validation process where they're actually looking at the EMR screen and comparing it to the information that was reported through the feed and confirming that the information matches, right? So it's confirming that the information is mapped correctly and that the information is the same on both ends. So it's a step that the HIE does. It's not what the plan does. But the benefit to that is if a data set is sort of approved through that program, we can then take it in that standard format and load it into our HEDIS engine, and it's considered standard and validated. And there's really no additional, there's some validation that the plan would do typically, with any data source they use, but there's nothing extra. It would be considered standard supplemental data, which is great.
That's terrific. And I'm just going to do one more question so that we can get to the rest of our agenda. But are you looking at or hopeful that providers will focus on high risk, high cost patients first?
Yes,
say the chronically ill and cancer patients.
Yes, and that is exactly what we did. We actually created a subpopulation, so it's not all members needing that follow up, extra care and extra handholding through the discharge process. We really identified our high risk patients in the measure that we introduced first to our hospitals and then spreading it to our primary care. So that 7-day post-discharge requirement is for our highest risk members. We do ask for our lower risk population for our primary care providers to still follow up with those patients within 30 days. So we do have a tiering approach there.
Wonderful, wonderful. Thank you. And Jania, I just am hoping that we can follow up with questions. I think there'll probably be a lot more detailed questions and technical questions, but thank you for being part of today as well as being part of the coalition, and we really appreciate IEHP's leadership in our work.
Absolutely. Happy to be here. Happy to help with questions later. Thank you.
Okay, great. Thank you. So I'm going to turn it over to Robbie, who I think is going to walk us through. For those of you that are on our call 2 weeks ago, we had a presentation by CPEN around some pending legislation. And then also I think Felix, you're on and can give us an update on the budget ask. So Robbie?
Yeah, thanks to me. I'll start with SB 1033 first. I know we've got Andrea on from CPEN. We just wanted to follow up with the coalition to kind of determine next steps. Just as a reminder, so SB 1033 would require commercial health plans really to utilize best practices around the collection and reporting of demographic data around their health plan members. So including things like age, sex, race, and the like. It would also require the state DMHC to provide technical assistance and other incentives to health plans. I think what we'd love to do here is really, I guess, answer any remaining questions that folks have. And I know we have Andrea on the meeting as well to help with those. But also to, per, I think, staff's assessment of the bill, thought that, this seems like a bill that aligns with our priorities and principles and could be something that the coalition supports. So would love to hear too if folks have any thoughts or comments on that as well in terms of, turning around a letter of support potentially on the bill. So I guess with that, we'd love to take any questions or comments anyone might have.
I think, Robbie, our intention would be able to send around a letter of support early next week. And then like we've done on other letters, we would open it up for your edits or comments, and then we'll turn that around with incorporating those edits.
Awesome. Well, I guess if there's no questions or comments, feel free to send us, an email or any suggestions to that letter we can circulate early next week. And thank you, Andrea, so much for your time at our last meeting and your presentation as well.
Yeah, of course. And thank you all so much for, considering this bill to be prioritized for your coalition. We're very excited to, have your support and happy to answer any questions if folks have any. So thank you.
And Andrea, I think what we discussed is that we would turn around a letter of support from the coalition, but then also send out the toolkit that you provided so that individuals and organizations can do their own letter of support as well. So we'll make sure to include that. Okay, great.
And that's helpful, actually. I may follow up with Robbie to just provide you with we have like a general outreach template that may be helpful for folks in this space, as you may want to reach out to other groups or perhaps just get other pieces of information. So I'm happy to follow up with Robbie and share all of those materials.
Excellent.
Great, thank you.
Andrea. Well, awesome. Well, I guess too, we just wanted to be able to make a little space too for any budget updates around the ask that was made recently for a Medi-Cal focused performance and incentive program. I don't know, Felix, if you have any updates on that work as well.
Yeah, well, thanks, Robbie. Right now, the update is, obviously the effort is remains in motion, which is great. And to that effect, we had our second, I know it's confusing, but there's a second separate series of meetings that supporters of the budget request, those that have officially signed on with their logos and their organizations to gather and to plan for the next steps. We had that second meeting, I think it was a week ago, if not, maybe it was 2 weeks ago, but where we got down to some of the more brass tacks of who would be potentially best situated to be the messengers for key offices, key legislators on both the Senate and the Assembly full budget committees. So that's very exciting. I think the way it broke down was, not surprisingly, where an organization had a geographical connection to a legislator by virtue of their district and or had another sort of pre-existing relationship, that they would be best situated to help carry the ask and make sure that it was amplified through these conversations, through this, internal grapevine that obviously the legislature has amongst one another to actually make our proposal rise further to the top. when it comes down to final deliberations on the budget. In terms of so one plug there is obviously for those on this group who have been on the fence, have been kind of thinking about whether it makes sense to throw in your lot with the effort. I think it's only growing stronger, and we will definitely always have the door open for any and all comers. And we'd really be excited for you to join, not just to again make our coalition letter bigger and flashier, but to actually have more voices and more live, warm human bodies and stories actually calling into these meetings with the members to tell them why this request is so important. I believe the next formal hearing of issues on the budget is on April 25th on the Assembly. I think formally they call it an open issues hearing for the Assembly Sub 1 Committee on Health and Human Services, but we believe that is where stakeholders will have the opportunity to do what was similarly done on the Senate side, which is to call in and just do a quick 30-second me too on behalf of my organization. We also support this request for data sharing infrastructure and incentives. So we will obviously feed out more information on that when we get it, but please mark your calendars because that is the next milestone on the horizon.
Excellent.
Yeah,
well, thank you, Felix, and we'll make sure to put that on our calendar and share that with the coalition too, and kind of stay abreast of any updates. And if it's okay too, if we can offer that if folks are interested in joining the sub coalition to reach out to you.
Yep, as always, and/or Iehp. And I would be remiss to say, obviously, I echo Timmy in terms of being so thoroughly impressed with Jania's overview of their program. And again, really wanted to impress upon everyone that, if you liked what you saw from Jania, think about how that would look if it were replicated up and down the state. That is what the request is really all about.
Excellent, exactly. Well, thank you for the update. I'm looking forward to the hearing on the 25th. I see a couple other questions came in around SB 1033 from Doug and David. Just to acknowledge those two, there are pieces of 1033 that lean on US CDI and OMB standards around data standards, and then also there is a piece in there around best practices. And DMHC providing some assistance to plans on highlighting what those are. So we can make sure we'll also recirculate the fact sheet around 1033 that CPEN has put together, which I think offers a really good summary of the bill and what it's looking to do. So we'll make sure to get that around as well. Excellent. Any other questions on any state policy updates at all?
Questions for Felix?
I don't know if this is an update, but I'd just like to say, Timmy, I heard you say that you were a state of reform. I'm sorry, I didn't know that. So I'm sorry I didn't see you yesterday. But anyone who was there can say that Assemblymember Jim Wood started off the day talking about the huge lift that California has and the promise for a healthier California with all of the work that we're doing across Medicaid reform and CalAIM and everything. And regarding this budget ask, he is our sponsor. And one of the things that he said that stood out really, really clearly for me was that data is the key to everything. And he is a big believer in that data. So I think we're really lucky to have him sponsoring this budget ask. And, the rest will be up to us to really, if this is important, and it is the key to achieving what California hopes to. I think it'll be very difficult to achieve those CalAIM goals without incentive payments for Medi-Cal providers and without key infrastructure funded for health information exchange. So I just wanted to say it's on the state policymakers' radar, and it was good to hear that.
Yeah, I echo that. I heard data as being a real key theme of the day, and also in the CalAIM panel, it was HIE and data exchange and social services being part of that was really front and center. So hopefully there will be some good coverage with some of those key takeaways and themes. We should do some follow up there. Thank you, Mimi. And next time we are at these in-person events, let's make sure we do a meetup So let's, oh my gosh, it's so fun to start seeing everybody in person. Robbie, do you want to move us to our next slide? There we go. So very
Yeah.
quick update on the data sharing format.
Yes, and I just dropped the link to our letter that we submitted around the budget too for reference in the chat. Yeah, just I guess briefly around the data sharing agreement. I think some of the highlights here, really the staff at Cal HHS provided a set of new topics for the subcommittee to review, including uses and disclosures, and then also application of the minimum necessary standard. I think some of the feedback that was provided during the discussion around these topics, as well as an earlier discussion topic around qualification of HIEs or HIOs, was that it seems like a qualification process is needed. It may not be needed for every organization, but that ideally there would be a qualification process for intermediaries, as well, that creating this authority would need to reside somewhere within a health agency and require some staffing as well. There was also just some feedback around some of the provisions that were proposed in the data sharing agreement draft that was circulated a while, just around the need for some better definitions of what certain terms mean, and also too thinking about how qualified entities are contemplated in the agreement. So not just kind of individual organizations, but how can we create a data sharing agreement that also sees those intermediaries, the HIEs, the HIOs, and the networks as participants in this work too. So those are some of the highlights. I think in
My
terms
big
of
takeaway was that we need to make sure that an organization, if they sign on to a third party to be able to kind of facilitate that data exchange, that they're not then needing to continue to do all of that, like responding to queries themselves. It needs to go go to that third party. So there needs to be some way of being able to make it more efficient for these organizations.
Yeah, and just one
That's my
other
takeaway.
too, is just around policies and procedures. So the group is planning to release a draft in early July, which will include things like governance and accountability and the like. So we'll keep an eye out for those as well, and any drafts that circulate in the meantime. I know we're at time, Timmy. I think I'll hand it back to you.
Yeah, just to wrap, we are going to look into having our own data identity workshop. So we'll look for invites for that. If you want to be part of it, reach out to us so that we can relay that back to RIM and be part of the process, outside of the process, I guess. And then in the next, let's just go real quick, just to highlight for you all things that we're reading. Whoops, can you go back to, there we go. Oh, okay. We have a blog out from the last data sharing agreement that also gives our sense of what we spoke about at on our last call, of kind of pulling together our insights around the data governance discussion. So take a look at that. Next slide. California Healthcare Foundation and our friends at Intrepid Ascent, who are, I think, on the call today, put out a fabulous update around the levers that the state can pull to be able to realize data exchange. This is going to be one of a series, and we've invited Mark and his colleagues to come on board on our next call, which will be, oh, I'm sorry, I think they're going to be on the next call, not the 21st. I think it'll be the 14th. So this is just, we need to update the slide, but they'll be on our call on April 14th. So mark your calendars there. And while I'm at it, while I've got all of you, April 7th is the data exchange framework meeting. So if you have it on, look on your calendar right now, you have to actually, because we're using Zoom, delete that meeting off your calendar. We want you to go to the data exchange framework one instead. And then you should have on your calendar a substitute, which will be April 14th. And then we'll meet on April 21st as well. So we'll be making, Kira will be making sure you get that right through email, but there's your PSA. Next slide real quick is, yeah, so HITAC, there's more information there. They have an RFI out there that you might want to look at. Take a look there. I'm going to just go through these. Next slide. So when we talked about the ONC data blocking or information blocking, this is a really nice article that really calls out that there's zero enforcement. Something we need to be paying attention to as we go forward with the data exchange framework. Next slide. HIMSS highlighted, just like state of reform, highlighted the need for us to be able to get going on modernizing our data infrastructure. So something to look at there. And I think that's it. One more for you to take a look at. So thank you everybody for coming today. We have our programming the rest of the month as well as in April. Take a look at the calendar that's in your attachment. And thanks again for coming. We'll talk soon. Have a great day.